Hi, folks. Welcome to our training on the implementation of opt-out testing for HIV and hepatitis C in syringe services programs. My name is Tyler Bartholomew. I'm an associate professor here at the University of Miami Miller School of Medicine. I am joined today with my colleague, Dr. Tukes. Do you care to introduce yourself real quick?
Sure. Thanks, Tyler. I am Hansel Tooks. I'm professor of medicine here at the University of Miami. And back to you, Tyler.
Appreciate it. And so today we're actually going to spend our time in this training focusing on how to implement opt-out testing. This is something that we did early on in our days when we opened the first sanctioned syringe services program here in Florida called ID Exchange in Miami. One of the things that we really focused on doing was trying to innovate and implement best practices around HIV testing, Hep C testing, and linkage to care. And so one of the approaches that we've taken is what's called opt-out testing. And so today we're going to review what opt-out testing is, how this gets utilized and implemented in the SSP context. And hopefully from this training, you all will learn more about the language, how this actually functions in the real world setting, and how you might actually use this type of language and approach in your specific SSP. So just a quick overview of our training. We're going to describe the rationale and benefits of opt-out testing for both HIV and hepatitis C within syringe services programs. We're also going to explain key principles of consent as it relates to opt-out testing and how it differs versus opt-in testing, confidentiality and how important it is to make sure that we do testing in a confidential space, especially thinking about how this gets implemented at fixed locations versus mobile locations or outreach or street-based locations. The different types of modalities are going to lend itself to different types of confidentiality and considerations. And then ultimately the appropriate language that needs to be used for opt-out testing. We know when this gets implemented improperly, it can lead itself into coercive nature, coercive practices and policies. And so we want to ensure that we are reinforcing the positive and good language and using good examples of language to use when delivering opt-out testing. We're also going to demonstrate how to deliver an opt-out testing using clear client-centered communication. We're also going to have a discussion on the ethical considerations around opt-out testing. There are several ethical considerations, especially when we think about this for people who inject drugs and for syringe services programs. So we really need to make sure that we address those and think about how they actually play out in our settings. We're also going to highlight the benefits of implementing opt-out testing within this context. We'll show a case example from our program here at ID Exchange in Miami, and the effect that we had on our testing uptake after we implemented opt-out testing. And so that will be our case example that we will run through. So just briefly, why should syringe services programs be testing for HIV and for hepatitis C? I think we all understand that the traditional healthcare system has fundamentally failed people who inject drugs. So a recent national insurance database study demonstrated huge missed opportunities for HIV and hepatitis C testing among people who inject drugs in traditional healthcare settings, with over 90% of people who inject drugs not being tested for HIV or HCV upon clinical encounter in the US between 2010 and 2017. And we also know that SSPs, or syringe services programs, are community-driven, non-stigmatizing programs that are frequented by people who inject drugs. So research also suggests that only 44% of our community, of our population, report actually going to a primary care visit or a traditional healthcare visit in the previous 6 months. However, 78% report going to the SSP at least twice in the previous 30 days. So we know that this is a touch point, a frequent touch point for our population, and really allows us to do better engagement than traditional healthcare settings. And we also know that people who inject drugs engage in SSPs are more likely to actually receive a test for HIV and for hepatitis C. So a recent meta-analysis showed that people who inject drugs who access SSPs were 1.6 times more likely than those who did not access an SSP to have had an HCV test and an HIV test in the previous year, which this highlights the important role that SSPs actually play in reaching people who inject drugs. And so delivery of HIV and Hep C testing within the SSP setting has also been shown to be acceptable and feasible and highly preferential to people who inject drugs. We know this is the location where they want to receive services and have this type of service implemented and offered. And when we bundle our testing together, where we offer HIV and Hep C testing, point of care at the same time, we actually see improved linkage to care outcomes, which is really, really important. But fundamentally, what we see on a national scale using NHBS data, we actually see a national decrease in HIV testing and Hep C testing post-COVID among people who inject drugs. So that tells us we really need to do more work in engagement and understanding how we optimize and improve uptake among people who inject drugs. But what we do see from the research literature is testing uptake remains very low among SSP clients. And so when we look at this national study that was conducted, these data are a little old at this point, but this is the best available data that we have. When we look at implementation of point of care testing for HIV and for hepatitis C, we see the majority of SSPs in the United States actually do offer HIV and HCV testing. However, only about 15 to 17% of clients actually receive on-site testing. And we actually see there's a little bit of a difference between the frequency of offering HIV testing versus hepatitis C testing in our programs. But what this tells us is that the current policies and procedures on how HIV testing and hepatitis C testing is offered within the SSP context actually fails to support widespread reach by optimizing participant uptake. So that's what we're really going to focus on is participant uptake, receipt of testing, and how do we offer testing in a non-stigmatizing way that allows people to receive this test and then further their public health outcomes. So there's two different types of approaches that we typically consider or we can think about that has utility when it comes to implementation in the SSP context. One is opt-in testing, as one is opt-out testing. So when we look at opt-in testing and define that, we know that clients must actively request the test, which can create barriers due to stigma, fear of the test result, or fear of retribution of engaging in that type of service, or lack of awareness around the HIV test itself or even the hepatitis C test. Opt-out testing usually also includes pre-test counseling, which we know is not evidence-based, and individuals actively choose to receive the test. So there's an entire consenting process that has to go in that's separate and aside, usually than the traditional consenting to receive services within your organization. So keeping it separate and not integrated into the workflow, keeping it ancillary that they have to opt in and actually request a test can put up lots of barriers and potentially are reasons why we might see lower testing uptake among people engaging in SSPs, especially around this type of testing. Now, opt-out testing on the flip side, clients are actually informed that testing for HIV and hepatitis C will be included as a routine standard of care of your program. Given to all clients, and that they may decline the test if they choose to do so. And when we see and compare these two types of approaches through both systematic reviews and meta-analyses, we know that opt-out testing significantly increases HIV testing uptake across various settings compared to opt-in testing. We also know that opt-out testing for HIV is highly effective at identifying new diagnoses, reduces stigma associated with HIV testing, and is highly cost effective compared to other testing strategies. So there's growing and emerging and really robust data on the effectiveness and cost effectiveness of doing opt-out testing. And we know with recommendations from the Infectious Disease Society of America that all people who inject drugs be screened for HCV annually and HIV annually. Healthcare providers such as emergency departments, federally qualified health centers, primary care clinics, and jails have really moved into integrating routine opt-out testing for both HIV and for hepatitis C. However, there has really not been large-scale adoption of this approach in non-traditional settings such as syringe services programs. And this approach is not something that is new and novel. It's new and novel to the context, but not to the US and how we have viewed testing for HIV historically. So what we see is that the CDC has long endorsed opt-out testing for HIV. This was guidance that was provided back in the early 2000s, I believe, or mid 2000s. And then they officially endorsed opt-out testing for hepatitis C in their updated guidelines in 2012. So again, It's almost 12, 13 years old at this point with these guidelines, but we know that CDC has recommended this approach moving forward. Now, when you're implementing or before you actually implement opt-out testing, this is guidance from CDC. Every state is going to have different laws around the ability to do opt-out testing. And so before you move into actually deploying this type of strategy, make sure you check in with your local state laws around opt-out testing prior to implementation so that you adhere to those guidelines. As I mentioned, this approach has been used in many different types of settings, such as emergency departments, primary care settings, inpatient hospital settings, correctional facilities, substance use treatment programs. And I put on there certain services programs, but really, when we look nationally, this type of approach is not used and highly underutilized by certain services programs. Now we get into what are we talking about when we say opt-out testing and how this kind of looks and what are the configurations that we are considering when we're doing opt-out testing. The first one is this idea or notion of presumptive consent, and this is an important concept to understand. So clients, when they come into the program, are assumed to consent to testing unless they explicitly state otherwise. Now, opt-in testing, on the other hand, we view this as the light's not on and they have to flip the switch to turn the light on. Now, on the flip side, opt-out testing is saying that the light switch is on and that people have the ability to turn that light switch off. So they can say, no, I don't want to receive testing. They can opt out of the process and then they can move forward and access services. Now, the approach of having the light switch on, it can actually reduce barriers to access and again, preconceived notions, the psychological components, the behavioral components that might have somebody choose not to actively request an HIV test or a Hep C test. And opt-out testing fundamentally makes it testing routine and much less intimidating of a process or a procedure since it's normalized into the existing SSP infrastructure. Now, beyond presumptive consent, we also need to think about informative communication and how testing is being offered. So clients are provided with clear information about the testing process, what they should expect, the finger stick process if you're using a finger stick technology or test, the purpose of the test, and ultimately the benefits of knowing their HIV status or their hepatitis C status. So this transparency around the testing process itself, what to expect, and then ultimately the benefits of actually knowing your status as far as linkage to treatment or linkage to prevention services, that transparency helps us foster trust and reduces anxiety for clients that are engaging in the testing process. And then ultimately, kind of core to what we do in harm reduction is we always remain client-centered in the approaches that we do. And opt-out testing from the literature perspective and from real-world implementation has shown to destigmatize testing itself by normalizing it as a process. And so by doing so, we again think about how we destigmatize substance use, we destigmatize engagement with certain services programs. And so this type of approach actually fits really nicely into what we do in harm reduction. So while participation in testing is encouraged, clients ultimately maintain the right to refuse testing without any negative repercussions when it comes to your program. And that's really an important concept to have and understand. And we'll go through good examples and bad examples of what this looks like. But ultimately, we always want to respect the autonomy, and that is crucial to maintaining a supportive environment for our clients. And so when we design our opt-out testing strategies or policies around it and the language that we're going to use, these three principles must be taken into consideration and thought about prior to implementation. So how could this testing approach actually look like in your SSP? So this is just a simple workflow of how this might actually look like or how this could be implemented in your SSP. So when we think about initial engagement, this might be something upon enrollment into the SSP. Our clients are informed that they will be offered HIV testing and hepatitis C testing as part of their intake visit. This communication should be provided clear. It should be welcoming to individuals. I feel like SSPs are fundamentally amazing at doing these type of things. The second component is informational brochure. So beyond just saying this is part of the process, provide clients with simple information or a sheet or a flyer that outlines what HIV testing and Hep C testing involves, why it's important to do it, and what clients can expect during the process. And so this can help alleviate concerns and clients can ask questions. So I would encourage, or you should encourage your clients to ask questions related to the testing process. Again, the transparency fosters trust and communication. Then, as you move forward in that encounter, providing a clear option to opt out of the testing process. So, staff should ensure that clients understand they can opt out at any time in the process. For instance, staff might say, as mentioned before, HIV, HCV testing is part of routine care that we provide, but you have the right to object or decline either test. Do you have any questions regarding HIV and HCV testing? And you can further highlight that declining testing will not impact the services that they have access to in your syringe services program. And then after, let's say they say yes to doing the testing, you go through the process of testing the individual, you ultimately want to set a solid follow-up plan after the test itself. So for clients who do consent to testing, we want to ensure a seamless process for receiving the results. Oftentimes we're doing point of care testing, so we can deliver these results within 15 minutes or so, and then any necessary follow-up care that's needed when planned for that. And so this is true for those who also test non-reactive as well. We have amazing prevention for HIV at this point in time through PrEP. And so making sure we have status neutral pathways into care for folks that are reactive and non-reactive on point of care is really, really essential. And so this type of workflow, as presented, can be implemented during an enrollment process if you have a formal enrollment process at your SSP, or it can be integrated into the encounter or encounter level or daily exchanges that you might have during your engagement activities. So when we think about examples of good communication and opt-out testing, there are kind of five domains that I like to present and think about, or allow you all to think about when you think about structuring the narrative or structuring the language that you're going to use. So the first one is to be clear and informative. So an example of this is, as part of your enrollment visit today, we offer testing for HIV and hepatitis C as part of routine care, just like syringes and naloxone. You have the right to decline the test. This helps us ensure you receive the best care possible. We also want to encourage participation. Routine testing for HIV and HCV is an important step in managing your health. Many people find that knowing their status helps them make informed choices about their care. We also want to respect autonomy, so you have the right to decide whether you want to be tested for HIV or HCV. If you prefer not to, just let us know and we won't proceed with the test. We also want to focus on normalizing this process within your integrated workflow. And so HIV HCV testing is part of routine services that we provide at our SSP. It is a common test that many people take to stay informed about their health. And then ultimately, we want to emphasize support and say, we are here to support you in your health journey. If you choose to have the HIV HCV test, we will provide you with all the information you need, regardless of the result, and answer any questions you may have. So thinking about how you want to structure your opt-out testing approach, you should really engage with your community, run through these types of examples, try to understand what resonates the most with your population. And so before you even go to implementation, always go to the community first to make sure that whatever policy you're putting in place, whatever program you're doing, whatever language you're using is acceptable to your clients. And then on the flip side, we also have bad examples of communication. I want to present the bad side, so just to bring kind of awareness to the things that we do not want to be implementing when we're doing an opt-out testing program. So the first one is coercive or pressure-inducing language. So all new participants must be screened for HIV and HCV as part of the enrollment process. If you do not want to be screened today, we will enroll you at a time when you are comfortable with testing to access our services. So again, coercive testing, forcing people into testing is an improper use of opt-out testing, and fundamentally is not opt-out testing as it's being implemented. Vague language, we also don't want to use vague language that's not detailed enough to provide consent or understanding of the testing process. So you might want to consider getting tested for HCV. It's up to you, but many do it. Again, not very clear language. We also don't want to diminish autonomy. So we will be testing you for HIV and HCV unless you say something. Just let us know if you don't want to be tested, but we'll do it anyway unless you opt out. So again, that's improper language that we don't want to be using. Stigmatizing language. Fundamentally, we should never be using stigmatizing language. So if you've been using drugs, you should definitely get tested for HCV. It is something that we need to check. And then we don't want to ever diminish client concerns. So don't worry about it. Everyone gets tested here. I know you may not want to, but it really is standard procedure. But with the good and the bad, when we think about using respectful, clear, and supportive language, we know that we can significantly enhance the effectiveness of opt-out testing approaches. We know it fosters trust for our clients, encourages participation, and ensures that clients feel empowered to make decisions about their own health. And conversely, using coercive, stigmatizing, or vague language can actually deter individuals from participating and create barriers to care and barriers to access. So, tailoring your communication to be client-centered and empathetic really remains key to the successful implementation of opt-out testing. Now, there are also important ethical considerations. I think there's a lot of ethical thoughts to be had related to opt-out testing in all different types of settings, but especially for SSPs. The pros of doing this type of approach are increased access to care. So again, opt-out testing facilitates broader access to healthcare services that historically our community has not had access to, and allowing individuals who might not otherwise seek testing to receive it. So, and we know that earlier diagnosis of these conditions lead to improved health outcomes in the future. There's also a public health benefit, so increased testing rates can contribute to reduced transmission for HIV and HCV within communities, which improves the overall health of our population. We also know it reduces the stigma related to the test. So opt-out testing normalizes the testing process and helps destigmatize testing, ensuring equitable outcomes that we see. We also encourage engagement, so individuals may be more likely to engage in health services when testing is routine. And then ultimately, this consent and autonomy. So clients are provided information regarding HIV and HCV, enabling them to make informed decisions about their care. So opt-out testing must always fundamentally respect the autonomy of our clients by retaining the right to refusal. And this is where people can do this wrong, is diminishing someone's autonomy, compromising their autonomy, and not presenting a clear pathway to refusal for the client. So think about the pros to that and the cons to this related to potential coercion, which we've already discussed, concerns about disclosure around testing, and then quality informed consent. All of these can be handled by thoughtfully thinking about how testing is going to be implemented and the type of language that you're going to be using. So now I'd like to call in my colleague here, Dr. Tukes, who's a harm reduction physician, to kind of open a conversation around the ethics of opt-out testing. And so when we think about implementing opt-out testing in SSPs, we know there are several ethical advantages, such as increased access to care, reduced stigma, and enhanced public health outcomes. However, it also raises concerns, or important ethical concerns, regarding patient consent, privacy, and the potential for coercion. So addressing these ethical considerations has to be considered during the implementation process to ensure clear communication with clients and staff while performing opt-out testing. So, Dr. Tukes, I'd like to understand your thoughts and your perspective as someone who has implemented this, who has championed this in our SSP. Is it possible to actually balance these ethical considerations for SSPs?
Absolutely. I still remember when you came to my office and you recommended that we implement opt-out testing at IDEA. And at first, I was really hesitant because I thought that there was the potential for coercion. We had just opened. I wanted to make sure that we earned the trust of the community prior to a really major service delivery change like opt-out testing. But I really came full circle on this. The systematic exclusion of people who use drugs from healthcare for decades, it's really opt-out testing provides the opportunity to right that historical injustice. With the sobriety laws that some states have, Florida had a policy that folks who are using drugs could not receive treatment for hepatitis C. Insurance companies have policies where they do not approve medications for folks who are using drugs. Our community deserves access to care, and that is built upon a foundation of testing. We are able to test, and then we're able to provide life-saving medications to people. Once somebody's diagnosed with chronic hepatitis C or acute hepatitis C, we have life-saving drugs that can preserve people's health, the health of their liver. Regardless of the result of somebody's HIV test, that we have access to antiretrovirals. That can be in the form of PrEP, or that can be in the form of treatment. We really like a status neutral approach. But I will tell you, opt-out testing implemented at IDEA in 2018, and now a month ago, we delivered long-acting injectable PrEP to somebody at IDEA because they are deserving. Right after that approval happened, we had the foundation. We could diagnose somebody as being potentially at risk of HIV acquisition and give somebody access to PrEP. It's hard because opt-out testing in an SSP really allows our community, which is deserving, to access healthcare on their own terms. Um, there has to be access to life. There has to be access to care, and healthcare is a right. Harm reduction is love. Our community is deserving, and I think that opt-out testing is the foundation of bringing healthcare to a community that's just been excluded for decades.
Amazing. Amazing. Thank you for your thoughts and consideration. And we've had these conversations ongoing now for the last 8 years since doing this type of approach. And it really has been foundational into IDEA. It's been foundational to building all of the existing services that we currently offer. And so everything kind of came from doing this type of approach where we are able to give access to so many different individuals that would never have access to these services through this type of testing approach. Now, how do you feel about it fitting into the existing harm reduction principles that we always think about when we're delivering harm reduction strategies or interventions?
Harm reduction is healthcare on our own terms. And so, what better place to deliver opt-out HIV and hepatitis C testing than a harm reduction program that really reclaims HIV treatment and prevention, reclaims hepatitis C diagnosis and treatment, and brings it into a place that's non-stigmatizing, loving, harm reduction focused, a place that respects the bodily autonomy of folks who use drugs and has it in the most appropriate place. We all know the traditional healthcare system treats folks who use drugs terribly. Until we have the next generation of physicians trained, and we are working on it, we need to set that healthcare system aside and we need to bring high quality access to life-saving medications, life-saving preventive interventions to our community where where they are comfortable, where they're treated with dignity and respect, where they are greeted with love. And that's how we integrate testing into the SSP workflow. I mean, it is completely aligned with harm reduction principles because it's a reclaiming of health, the health of the community and the health of the individual. It's reclaiming it in our space, and that's why it's been beautiful to see all of the testing. We led to the diagnosis of the HIV cluster. That allowed us to at first link people to care, but then decide that we could better treat people at IDEA. I mean, we are so excited for you at this moment to implement opt-out testing because this is the opportunity to build the foundation of the one-stop shop at your SSP. And I think harm reduction is love, but harm reduction is also a one-stop shop for our folks.
Yeah, absolutely. Couldn't have said it better myself, Dr. Tukes. So thank you. Thank you for that insight. Really, really helpful. And hopefully helpful for you all watching this when you're thinking about doing opt-out testing within your SSP.
There are concerns, surrounding like the criminalization laws. We have criminalization laws in Florida, so privacy is a major concern. But we are confident that if you're able to maintain privacy and confidentiality and get people access to life-saving care, your community is going to benefit greatly from this intervention.
Yeah, absolutely, absolutely. And I think we want to, not only provide kind of the research and what has been talked about in opt-out testing, but also just show a real-world example of what this actually looks like in the SSP context. So we're going to move into a case example, and this case example comes right here from our back door, the Idea Exchange in Miami. So, just a little bit about IDEA Miami Certain Services Program. The original legislation was passed in July of 2016, and this legislation, called the Infectious Disease Elimination Act, or IDEA, authorized the University of Miami to implement a syringe exchange pilot program. It was a 5-year pilot program, unfunded by the state, had to do one-for-one exchange, but allowed the first legally sanctioned program to actually be implemented across the entire state of Florida. decriminalized possession, distribution, or exchange of needles and syringes, and then also allowed us to provide sterile injection equipment throughout Miami-Dade County. And the original ordinance back in 2016 was only specific to Miami-Dade County, so it didn't apply to the rest of the state. But this was an opportunity for us as individuals implementing this program or tasked with implementation to really think about what we can do and how we show that this program is effective in our state. So we could go back and advocate for further expansion of this program, broader scale implementation. And so really IDEA was the precipice of moving the sanction programs across our state forward. So IDEA Miami opened on December 1st, 2016 on World AIDS Day. And originally the testing policy around the enrollment process and the exchange process at IDEA was a opt-in policy. And so during the opt-in policy phase that we had comprehensive syringe services were offered to the participants, and they could request an HIV test or an HCV test. So that opt-in kind of approach was part of the menu, but they had to actively ask for a test. In addition, they were provided syringe exchange, naloxone, wound care, and a variety of other services that we have integrated at our SSP. And then in February of 2018, under a newly funded award that we implemented opt-out testing as our next policy. And so under the new opt-out testing policy, participants were informed that HIV testing and HCV testing was part of routine care at the SSP. However, they were allowed to decline the test at any point in time. So we actually evaluated what actually happened when we implemented opt-out testing. And when did this evaluation, when we looked into the research literature, we were kind of shocked to see that this was kind of the first time this approach was being evaluated in the SSP context. Like we said, there's decades now of evidence for opt-out testing across so many different settings, but it didn't actually enter into the SSP setting until this point in time, back in 2016, 2017, 2018. And we really had the privilege of evaluating this type of approach. And so to evaluate this, we actually looked into all the administrative records, all the data that we collect at IDEA Miami between the very first day that we opened all the way to January 2020, right before COVID happened. So we have about 37 months of data to evaluate. And so we stratified the sample into the opt-in testing policy period, which is about 15 months of operation at IDEA, and then the opt-out testing policy period, which is about 22 months at IDEA. And so we really zoned in on the enrollment data that we had. So during the enrollment process at IDEA, we take clients into a confidential space. We run through what the expectations and the services are that we offer at IDEA. We do a brief intake. All data collection is voluntary. We'll report demographics, injection behavior, sexual behavior, substance use, things like that. But during that process, we also integrated testing. And this is where opt-out testing can really flourish and shine is during the enrollment process, that very first encounter that you have with an individual. And so we had about 500 participants in opt-in testing policy period, about 550 during the opt-out testing policy period. We then further divided the data into monthly reach estimates. And so reach were the number of SSP clients that were tested during that month, divided by the number of SSP clients who should have been tested during that month. And so we use a type of approach called an interrupted time series analysis. We're not going to get into those details, but this type of approach allows us to examine what happens during the opt-in testing policy period, the effect of opt-out testing policy immediately when we implement, and then the sustained impact of that testing approach across time. And so when we did this evaluation, and this is an article that we published in the International Journal of Drug Policy back in 2020, we actually saw a immediate and sustained impact on testing reach and uptake, specifically in the enrollment process at our SSP. So before we implemented opt-out testing, that first month that we were operating, we had about 21% of clients accepting HIV and hepatitis C testing. Now you can see across time that opt-in trend period, we were increasing our testing uptake by about 2% every single month, leading into our opt-out testing policy period. And right before we implemented, we had about 40% of clients accepting testing. This was really telling us that we were gaining trust in our community, we were responding to needs, And so that line really represents ideas integration into the community and the receptiveness of idea among our clients. Then you can see this disconnect in the line, and we see a 42% jump in testing uptake immediately after we implemented opt-out testing. So you see that big gap in the middle of our graph here, that dotted line down the middle. And so that jumped all the way up to about 89% testing uptake after we implemented opt-out testing, 89.7%. And so we actually see that trend continue on. And this was months and months, years and years after we implemented opt-out testing. And even with updated data, again, these data stop in January 2020. We're now 5 years past that. We run this same type of analysis looking now, and we still continue to have, on average, about 85 to 90% every single month of people accepting HIV and HCV testing. So just the change in policy, just the change in language can have profound impacts when it comes to testing uptake. Now, as Hansel mentioned previously, we actually identified an HIV outbreak or a cluster that happened through our opt-out testing approach. You can see right here in the graph in the middle of when we actually implemented opt-out testing. The black dots are an HIV non-reactive test among a client. And then you can see when we had reactive tests come back. So we actually identified 7 new seroconversions. So people who had tested negative with our program before, then we're testing reactive for HIV. And so this allowed us to respond, call in CDC, Florida Department of Health, to really investigate this outbreak. And so we would have never known that this would have happened unless we were doing opt-out testing and doing the level of testing that we were doing at our SSP. So not only does this approach increase testing, when we think about responding and identifying outbreaks for HIV and for hepatitis C, this type of approach is really fundamental for SSPs to be on the front lines like we always are on being really the first people to identify these types of outbreaks and be the ones to respond to them. So that outbreak investigation really led us to developing, not only how we're going to continue doing testing moving forward, and again, our relationship with the health department, but also moved us into a space of thinking about, all right, how do we actually build linkage to care models on top of this testing infrastructure? One of the important things of opt-out testing or doing routine screening is that you need to have a pathway of linkage to care set so that folks have that direct pathway no matter what the test result actually is. And so a lot of our new research and that we're focused on right now, specifically here in Miami and across our state, is trying to look at new linkage to care models and how do we improve and increase HIV treatment initiation, HIV treatment retention, viral suppression, PrEP uptake and retention among our clients. And so one of the things that we did was develop what we call our teleharm reduction intervention. And so this is a telehealth enhanced, peer facilitated, on-demand services integrated in our syringe services program. We offer low barrier access to ART for HIV treatment, PrEP, medications for opioid use disorder, and hepatitis C cure. We also have mobile phlebotomy that's integrated into this approach, integrated on-site at the SSP. Fundamentally, everyone receives services at the SSP. They don't have to go to clinic to receive their treatment. They can have an amazing HIV physician like Dr. Tukes here, zoom in and remain connected in care. That's all facilitated by our community engagement team and our peers with lived experience. They're doing the engagement on the front line where we're integrating with harm reduction supplies such as syringes and naloxone. And also here's your ART, syringes and naloxone, here's your PrEP medication. So again, normalizing these medications and integrating them all into one space and what we call a one-stop shop. And so from these pilot results, we actually see we did this during COVID. So we actually moved to doing telehealth before COVID hit and everyone started doing telehealth. But we piloted this intervention and saw that among 35 of our clients living with HIV that engaged in our teleharm reduction intervention, 78% were actually virally suppressed at 6 months, which, when we look at the research literature, is actually the highest reported viral suppression among people who inject drugs in the United States. And when we see nationally with new data that was published recently a few months ago, people who inject drugs fundamentally have the lowest viral suppression among every subpopulation, every group that is disproportionately affected by HIV. So thinking about how we advance not only testing, but also linkage to care, these are things that we're tackling in our research that we're doing. And we're currently studying this type of intervention for HIV treatment and a three-site randomized control trial. We're also testing it for HIV prevention and a randomized control trial. Now, for testing, we're very fortunate to have CDC reach out to us around opt-out testing. They officially endorsed opt-out testing in the SSP context back in February of 2023. This became best practice or was included in the compendium of evidence-based interventions and best practices for HIV prevention. This has been labeled as an evidence-informed structural intervention. It is the only one in the SSP context, and it's the only one endorsed for people who inject drugs. So really, this is our best available evidence, best available strategy that we have to increase access to HIV and hepatitis C testing and ultimately linkage to care for our population. So just some conclusions as we wrap up this training. We know that opt-out testing has really been shown to, across several settings, to be a superior approach to increasing HIV and HCV testing uptake through testing normalization, crucial for detection and treatment. We know opt-out testing represents a significant shift in how we approach HIV and hepatitis C screening in syringe services programs. We also know that higher testing rates and increased access to care will fundamentally improve public health outcomes and overall community health of people who use drugs. And by addressing the ethical considerations head on, providing comprehensive training, ensuring robust support systems, we know from experience and from doing this work, SSPs really can effectively implement opt-out testing as standard practice, leading to better health for individuals and communities. I'd like to just open the floor to Dr. Tukes. Any last words, any last recommendations to SSPs that are implementing or thinking about implementing opt-out testing?
Well, Tyler, first, you did a fantastic job, and thank you for bringing opt-out testing to IDEA. Thank you for bringing it across the state, and now we go nationwide. The first thing that I can say is harm reduction is love, so make sure that you lead with love and care, the same care that I know you interact with folks on a daily basis with at your programs. Uh, I've visited programs all across the world, really, and one thing that I can recommend is that it's so important to maintain privacy of individuals when you're doing this testing, a confidential space. I've been to a program that was testing at picnic tables in front of everybody. You know, you have to make sure you protect the privacy of the people that you serve. You also have to make sure that it's non-coercive. That's what I was most worried about when we implemented testing. People have to have ultimate right to say no. They have to maintain their autonomy, and they need to be able to know that they can, in fact, opt out of testing. You have to determine the appropriate frequency of testing for your community based on what the epidemiologic profile looks like, based on people's past test results, and make sure that the testing that you're offering is truly appropriate. Make sure that you have your data collection system together so that you can have the appropriate reporting of your testing results. And be sure to link to harm reduction informed providers so that you can make sure that the folks that you're serving are treated with love and respect wherever they're going to receive care. This implementation of opt-out testing presents a tremendous opportunity for your program, and we're so excited for you. Congrats on your first step towards a one-stop shop. Uh, this is truly community caring for community. And isn't that our movement's origin story? So
Yeah,
thank you.
thank you, thank you. And we thank you for joining our training today. If you're interested in reading more about the evidence around opt-out testing and SSPs, you can scan the QR code in the bottom left hand of this slide to pull up our evaluation that was published, as I mentioned, in International Journal of Drug Policy. And best of luck with implementing opt-out testing.